We're thinking now about the treatment of hypoxia. And I suppose the most obvious thing to say here is treat the underlying cause. So work out what the cause of the hypoxia is, correct the underlying cause, and the hypoxia should automatically be corrected. So is it an extrinsic hypoxia? Is there not enough oxygen in the air? Is it that there is a biomechanical failure of ventilation and that air is not being sucked into the lungs? Is it that some of the large airways are obstructed and the air is not getting down into the lung tissue? Or is it a pulmonary hypoxia? Has there been some trauma of the lung? Or is there some disease process in the lung which needs to be corrected? Or is it an anemic hypoxia? Is there a reduced oxygen carrying capacity of the blood that needs to be corrected? Or is the hypoxia caused by stagnation or relative stagnation of the circulatory system? Is the patient shocked? Do they have congestive cardiac failure? If so, we need to correct these underlying problems. Is the patient edematous in a particular area? If so, we can think about reducing the edema. Is there ischemic hypoxia? Do we need to consider revascularizing or somehow facilitating the reperfusion of an embarrassed area of ischemic tissue? Or uncommonly, is there a histotic hypoxia that needs to be corrected? So the underlying cause, and correct that if possible. But in the acute situation, the saying is A and B and oxygen first. So in an acute situation, we don't want to faff on for a while doing a detailed assessment. What we want to do is get some oxygen into the patient. And this is the saying. First, make sure there's a clear airway. Make sure the patient's breathing, or if the patient can't breathe, that you ventilate them. And then make sure the patient is being oxygenated. It's always airway and breathing and oxygen first. A and B and oxygen first. So that brings us on to thinking a little bit about oxygen therapy now. Now, if you're ever in an acute situation and you're not sure what to do, the right thing to do is to give oxygen. Because oxygen, if the patient is hypoxic and you don't oxygenate them, then they're going to get hypoxic tissue damage and all sorts of problems as a result of the hypoxia. And we can give patients oxygen at relatively high concentrations for short periods of time without needing to worry about it at all. There is one very minor exception, patients that retain a lot of carbon dioxide. But even then, as long as you're there to monitor them, it's not a problem. Way more patients die or suffer morbidity because their hypoxia is not treated. The most important thing is to oxygenate your patient. So if you arrive at a situation on your own, you think the patient might be hypoxic, give them some oxygen while help is arriving. So you're not going to do any harm by giving otherwise reasonably healthy people oxygen for a short period of time. So high concentrations of oxygen for half an hour or even a couple hours aren't going to do any harm. So if you're otherwise healthy now and I put you on high concentrations of oxygen for an hour or two, that's not going to do you any harm. So if in doubt, give oxygen. Once oxygen therapy is established, we'll probably give it normally concentrations are between 24 and 40% oxygen, depending on the clinical picture, the patient's needs, the oximetry results, and sometimes arterial blood gas analysis. And generally speaking, your patients who are poorly, if you have ill patients, then we want to maintain these patients with oxygen saturations of between 94 and 98%. So it doesn't matter too much what has made the patient ill, but we want to make sure that their oxygen saturations are 94 to 98%. Now, the exception here mentioned by the British Thoracic Society is for patients who retain carbon dioxide. These are patients who have got chronic respiratory failure, whose levels of carbon dioxide have been high over many years. And they're probably used to running low oxygen saturations anyway. And the target range for them is to maintain their oxygen saturations at 88 to 92%. So your poorly patients who are not chronic carbon dioxide retainers, that is the vast majority, we want to maintain their saturations at 94 to 98%. And for the few that are carbon dioxide retainers, we want to maintain their saturations at 88 to 92%. When patients are on oxygen therapy, it's best if they sit upright because that maximises the efficiency of their respiratory muscles. It will maximise pulmonary ventilation volumes. Also, if patients are sitting upright, that allows drainage of tissue fluid if there's any pulmonary edema and can reduce orthopnea. And the upright position also promotes dilation of the bronchial passages. Patients can just breathe better when they're sitting up. If oxygen is on for a long period of time, it might need to be warmed, and it's very probably going to need to be humidified as well. Because if the oxygen is not humidified, the airways can start to dry out. The mucus will start to dry out, and this will increase the viscosity of the mucus, and that will reduce the efficiency of the mucociliary clearance system. Because we want to encourage expectoration wherever we can. So oxygen humidification is often a good idea. Now let's just clarify what we mean by oxygen saturations at this point, I think. Normal oxygen saturations are about, normally it's 95 to 100% would be quoted as normal figures. I mean, just try it. Put an oxygen saturation probe on your own finger and you'll probably find your oxygen saturations are 96, 97, 98%, something like that. And if you take a few deep breaths, your oxygen saturations can go up to 99 or 100%. Now 100% means that all of the haemoglobin, it's amazing, actually all of the haemoglobin going through the lungs leaves the lungs 100% saturated with oxygen, as measured in the systemic arterial blood. So under normal circumstances, your lungs are working at 97% efficiency, which is really quite impressive, or 98% depending on what your saturations are. And a few deep breaths and it will go up to 100%. So the oxygen saturations are how saturated the blood is. And of course we measure this with oximetry, pulse oximetry these days. Now what happens with a pulse oximetry probe is there's two different lights. There's two lights shine from one side of the probe through to the other side of the probe. And one light is absorbed by oxyhemoglobin, and the other light is absorbed by deoxyhemoglobin. So one light is sensitive to the presence of oxyhemoglobin, the other light is present to the presence of deoxyhemoglobin. And then there's a clever little microprocessor in the machine, looks at the relevant brightness of these two lights, and from the difference in that, it can tell what proportion of the blood is oxyhemoglobin, which is oxygenated, what proportion of the blood is deoxyhemoglobin, is deoxygenated. And as we've said, normally there'll be 95 to 100% of the blood will be oxyhemoglobin and only 1 or 2 or 3% deoxyhemoglobin. But there are limitations to oximetry to bear in mind. In anemic hypoxia, it'll still work. In anemic hypoxia, it'll still tell you what proportion of the blood which is present is oxyhemoglobin, but of course there could be less red cells present. So after hemorrhage, for example, you might still get oxygen saturations of 99, 100%, but if there's only half as much blood going through the patient's veins, if there's only half as many red cells, if a patient's had a lot of intravenous crystalline or colloidal therapy, for example, then only half the amount of oxygen is going to go through. So it's worth bearing that in mind. And of course, oxygen pulse oximetry is no good really in histotic hypoxia because that won't tell you anything because that's at the level of the cells themselves. So in anemic patients, yes, you're going to get oxygen saturation figures, but they may be misleading. The other classic time where people get a bit confused with this is in carbon monoxide poisoning, because the current generation of probes can't tell the difference between oxyhemoglobin and carboxyhemoglobin. So if a patient's been dragged out of a burning building, they could have very high levels of carboxyhemoglobin. Their tissues could be extremely hypoxic, But when you put an oxygen saturation probe on them, you find out that the oxygen saturations are 100%. But in actual fact, you're not measuring the oxyhemoglobin, you're actually measuring the carboxyhemoglobin, which of course is completely useless to your patients. Now, when we're talking about pulse oximetry, the SaO2, the oxygen saturations that we talked about, sometimes they're described as the SpO2, the saturation of oxygen in the periphery. But it will still measure the saturations in arterial blood, so that's fine. Don't allow patients to paint their fingernails because that will alter the readings. And do use the alarm settings on the pulse oximetry probe. So when you're away for a cup of tea or attending to another poorly patient, if one patient becomes acutely hypoxic, the alarm will go off, and that will they will merit your attention, and they will appreciate that.